Good evening, everyone. Myself, Dr. Ankit. I am Associate Professor at Department of Respiratory Medicine, King George Medical University. Today, we are here for the lecture on the topic Type 2 respiratory failure and its management. As we are aware that respiratory failures are two types. Type 1 and type 2 respiratory failure. Type 1 respiratory failure which have low saturation, low partial pressure of dissolved oxygen. Type 2 respiratory failure which may have type 1 respiratory failure along with high CO2. So let's start. The objective of today's presentation is first understanding the definition and pathophysiology of type 2 respiratory failure. Then we will discuss identify key etiologies and clinical feature. After that, how we can interpret type 2 respiratory failure accurately, and then evidence-based management of type 2 respiratory failure. Let's move on. What is type 2 respiratory failure? Type 2 respiratory failure, also known as hypercapnic respiratory failure. It is characterized by high PCO2 level, which is more than 50 millimeter of mercury, and it often accompanied by hypoxemia, PO2 level less than 60 millimeter of mercury. And this type 2 respiratory failure results from alveolar hypoventilation. Alveolar hypoventilation leads to retention of carbon dioxide, and sometimes central issue which involve the brain stem also can cause retention of CO2 because of central respiratory symptom, central depression, and sometimes neuromuscular disease or weakness of the muscles, diaphragm also lead to the development of type 2 respiratory failure. And in, in compensation to the high CO2, renal system compensate this high CO2 with retention of bicarbonate. So most of the time when you see the ABG of acute patient, only CO2 is raised. When you see ABG of chronic type 2 respiratory failure patient, bicarbonate is also quite high in case of chronic type 2 respiratory failure. And this bicarbonate is because of chronic compensation. Now, if we talk about what is the common cause of type 2 respiratory failure in our country, smoking is quite prevalent. So the COPD is the most common cause in our country, followed by obesity hypoventilation syndrome, which also known as Pigwickian syndrome, neuromuscular disease, drugs, and sometimes chest wall deformity is also responsible for the type 2 respiratory failures. If we talk about the sign and symptoms of the type 2 respiratory failures, common sign of symptoms of type 2 respiratory failure are dyspnea, headache, and daytime somnolence. And when we evaluate the patient, we may found flapping tremor, cyanosis, sometimes patient is GC is poor, confused, or sometimes comatose, need to the intensive care management. For the diagnosis of the type 2 respiratory failure, we need arterial gas analysis, which tell about the compensation, any other failure is associated with respiratory failure or not, level of bicarbonate, and in those patients who have type 2 respiratory failure, we should check for chest X-ray, we should check for the cardiac abnormality through the ECG, or we should check for the symptoms of snoring, symptom of obesity hypoventilation syndrome. And those patients who are critically sick, we should check for the complete blood count, electrolyte, and TSH level. Now, let's see what is difference between acute and chronic type 2 respiratory failure. Acute type 2 respiratory failure develops suddenly. It does not give time to kidney to compensate this high CO2 level, to compensate the acidic pH caused by high CO2. So, acute type 2 respiratory patient have low pH and almost normal bicarbonate, while chronic type 2 respiratory failure patient have almost normal pH but high bicarbonate level. It is because time which give kidney to compensate high CO2 through the bicarbonate. Now, how we should manage the type 2 respiratory failure? First and foremost, you should treat the cause. If high CO2 because of respiratory disease, patient had obstruction, you should treat the obstruction. You should give the bronchodilator to the patient. If you are not treating the obstruction, patient not going to get relief from the high CO2. After that, if patient also have low oxygen level, saturation level is less than 90, you should provide oxygen to the patient. And if patient have persistent high CO2, it is not normalizing with the conservative bronchodilator therapy. You can consider your patient for non-invasive ventilation. And if non-invasive ventilation fail, you may consider patient for mechanical ventilation through the endotracheal tube. So these are the step-by-step approach. First, you should give the bronchodilator. A patient show the good response with bronchodilator, you can manage patient with bronchodilator. If patient is not improving with bronchodilator, patient have persistent high CO2, you can give NIV as a trial. If despite of NIV, patient is not improving, you may consider mechanical ventilation. If patient improve with NIV, you can continue your bronchodilator therapy along with the non-invasive ventilation. Now talk about oxygen. We have a doubt. Sometimes we have a doubt. Oxygen may suppress the brainstem, which can reduce ventilation of the patient and cause retention of CO2. So we should aware that we should not give high oxygen to the patient which do not require oxygen therapy. If patient oxygen is low along with CO2, we can give oxygen in measured way. So that oxygen should be maintained in between 88 to 92%. If you are giving oxygen which is saturating blood more than 92%, this high dose of oxygen may suppress the brain and may further deteriorate the patient, may cause worsening of the CO2, right? So whenever you giving oxygen to the patient, you should check arterial blood gas analysis, dissolved oxygen level, saturation of hemoglobin after half to 1 hour of the oxygen initiation. We have listened a lot about the non-invasive ventilation. It's quite helpful for the COPD patient, but it is tool. If you use wisely, your patient may get benefited with the NIV. If you are not using this wisely, patient is going to be deteriorate, going to die because of this. Indication of non-invasive ventilation is same. any cause which is causing type 2 respiratory failure, you can prescribe non-invasive ventilation. It reduces the mortality and it also reduces the mechanical intubation in acute exacerbation of COPD patient. So if you want to delay or if you want to avoid or if you want to provide benefit to the patient without invasive mechanical ventilation, you should try for the non-invasive ventilation. And same as I told you for the oxygen, you should check for the CO2 level after half to 1 hour of non-invasive ventilation administration. And during, and you know, non-invasive ventilation is not very easy type of thing, not very tolerable for the COPD patient. You should regularly check for the consciousness of the patient, tolerance of the patient, whether my mask is adequately fit or not, whether patient is comfortable or not. You should check regularly these things on those patients who you prescribe the non-invasive ventilation. Invasive mechanical ventilation is indicated in those patients who fail non-invasive ventilation or who are unconscious or who have severe acidosis, pH is less than 7.25. In those type of the patient, you can use invasive mechanical ventilation directly, right? And you should follow the strategies of low tidal volume, low PEEP to avoid the varotama. And those patients who you kept on the non-invasive ventilation, you should try to extubate those patients early if they get improved, right? Pharmacological intervention for type 2 respiratory failure, what I told you earlier, if patient have spasm, bronchoconstriction, you should give the bronchodilator, either short-acting, long-acting beta agonist. Systemic corticosteroid you can give, which can reduce the inflammation of the airway, make ventilation of the lung adequate. If patient have symptoms of infection, you may prescribe the antibiotics. And most of the time, COPD, terminal stage COPD patient also have heart failure. If you are, during the examination, if you are getting pedal edema, raised GBP, crabs in the lungs, you may also give the diuretics to the patient, right? So it's all about the type 2 respiratory failure and how we should manage. Now move on case-based discussion. Here is a case of 68-year female COPD with drowsiness. It's almost clear drowsiness means patient have high CO2. If let's see what ABG shows. ABG shows PS is 7.21, PCO2 is 68, PO2 is 52, bicarbonate is 30. Means bicarbonate is compensating the CO2. It is chronic type 2 respiratory failure. Diagnosis is acute on chronic type 2 respiratory failure, right? Why? Because patient suddenly deteriorated. It have COPD, but due to some infection or some exacerbating factor, now he came to you in worse state, in drowsiness state, right? So it is diagnosis is acute on chronic type 2 respiratory failure. What we can do, we can give an IV to the NIV for the CO2 removal. And obviously, we should give the bronchodilator and we also can give the steroid for the management of inflammation and spasm, right? Now, this is an MCQ for all students. Which of the following is not cause type 2 respiratory failure? This MCQ is for your self-assessment. Check what you got from my lecture. So the option of this question is myasthenia gravis, OHS, ARDS, and last one is benzodiazepine overdose. If you are able to give answer of this case question, means you are getting something from my lecture, right? Let's see what is right answer. ARDS, right? Let's summarize my presentation. Type 2 respiratory failure. What is type 2 respiratory failure? Type 2 respiratory failure is CO2 retention, which is defined by the high CO2 level more than 50 millimeter of mercury. It is caused by the hypoventilation, and the common cause of COPD is COPD, obstructive obesity hypoventilation syndrome, neuromuscular disorder, and type 2 respiratory failure managed with the oxygen, NIV, bronchodilator, and obviously addressing the underlying cause. For further reading, you can go for the GOLD guideline 2025 for the COPD, ES, ATS guideline for how to use non-invasive and invasive ventilation, and, and also you can go for the up-to-date provided by the university. Thank you everyone. For any query or question, you can mail me at ankyar007 @gmail.com. Thank you everyone.